All right. So, nervous system. I'm going to go talk about both the central nervous system and the peripheral nervous system. I'll kind of talk about the specifics in there. Again, I'm going to skip through a lot of this information. I'm going to be highlighting, so if you're taking notes, and I'm going to highlight the important spots that you definitely do need to know. Because, again, we're dealing with 192 slides on this.
Did you change slides?
This is exactly the same thing. It's just got a different background. So, yes, so this one I went through with Joe. This is actually just my background, but it should be the exact same one and match up with everything you guys have. Okay. So, if you feel like you don't see anything on there, let me know. But this, when I went through with Joe, we went through all these, and I actually have this split up into 2 lectures. You guys just have it as one large one. But you guys do have all this information. So when we're dealing with everything and the nerves, we're basically dealing with the nerves and the neurons, basically, the neuron body. Everything else is what's called neuralgia. So there's basically 2 terms. There's neurons and there's neuralgia. Neurons are basically what does our action potentials, it's our thinking. It basically brings in the information, it puts out the information, transfers that. Neuralgia is everything that supports it. And I'm going to explain all these details for you. So we have 2 major branches of the nervous system. We have the central nervous system and the peripheral nervous system. The central nervous system is everything that's in the brain and in the spinal cord. Everything that's bathed in the cerebral spinal fluid. That is all going to be our central nervous system. Our peripheral nervous system is obviously everything outside of the spinal cord of the brain, and that works on our body. So when we're dealing with the central nervous system, that's our brain and our spinal cord, and it basically is going to give all our higher functions. This is all our thought-related, this is our processing, this is maintaining our breathing, our regulation, homeostasis, all this stuff, things from going through the body. And it's going to tell us our greater commands when we're dealing with skeletal muscles of what we want it to do in motion, and it's through our higher process. Our peripheral nervous system is basically the highways, if you will, to transmit that information out to the body, and then it's the way for the body to tell the brain what's going on. So CNS tells the peripheral nervous system, we want you to do this. The peripheral nervous system will feed back and say, yes, we've done that. Oh, by the way, here's this sensation. Oh, by the way, we know this stuff. And it gives us the communication for the brain to think. I'm going to go over here, but the only other example of this is we also have a peripheral nervous system loop when we talk about hot surfaces. Again, if this is a very hot bottle and I touch it, do I want to take the time for that hot sensation to get up through my spinal cord to my brain to tell me it's hot, to say, no, we better pull it away? Peripheral nervous system does have areas that have its own built-in loop. So I touch it, it feels hot, it pulls away immediately without my brain even thinking, oh, it was hot. So we do have those. That's the only time the peripheral system does not talk to the central nervous system. So they're going to communicate. We have different type of receptors throughout the body that are going to communicate those every position of the brain, whether it's proprioception, whether it's baroreceptors, telling from pressure, all those different things. Any sensation and motor areas out there that we need to be able to tell, that's going to transmit back up to the central nervous system to reach the body and tell the brain what's going on. The brain is also going to work out through sending out symptoms to all the muscles, to the glands. That's what's going to help us to regulate everything. And basically the areas that we're going to reach out to are called effectors. So I'll explain that process here in a minute. Our peripheral nervous system is subdivided into 2 types of systems. So we have our central nervous system. Then of our peripheral nervous system, we've got basically 2. We have a division called the somatic nervous system and the autonomic nervous system. What do you think the autonomic nervous system controls? Automatic responses. Pretty easy from that. So that's going to be our smooth muscle system. That's going to be our body regulation. It's going to be a lot of our organs. A lot of stuff we have no control. Or our somatic nervous system is going to be what we do have control over, and it's going to be working over most of our skeletal muscle contractions, because those are things we do have control over. Where our autonomic nervous system basically covers our visceral. Visceral are our organs, so that's running our body that way. That's everything from smooth muscles that go down, our vessels that deal with glandular secretions, anything temperature related that we do, adipose tissue, all type of different aspects here. So here's a good picture of this. So our peripheral nervous system comes down, and efferent means we're going to be acting on an organ. So if I have an efferent is going to, that's my action. My efferent is going to be reacting or giving a sensation if I want this to be done. My afferent division is basically my sensory or my sensation. My afferent comes back to my brain to say, here's the response, here's what we're seeing, here's what I'm feeling, those type of things. So those are the two aspects. When it comes down, it breaks up into the two areas. The somatic nervous system, which comes down and works on our skeletal muscle, that's what we control. And our autonomic nervous system is our automatic aspect. It breaks down into two more divisions. So it breaks down into our parasympathetic and our sympathetic. And basically what those divisions do is those basically are our fight and flight or our feed and breed type symptoms. So our sympathetic is basically our fight or flight type of reaction. It's basically going to get our heart rate to go up. It's going to bring our breathing to go up. It's going to get our eyes to dilate. It's going to basically get our body to react to something. We're either going to fight or we're going to run, right? So it's got to get our body motion for that. Our parasympathetic is more of our feed and breathe type system. So it's going to actually cause our digestion to go up. It's going to cause our heart rate to go down. It's going to cause our respiratory rate to go down. It's going to get our glands going, secreting to go ready to eat and digest food. So those are the two different type of reactions that we're going to. Because we're going to talk about medications that affect our sympathetic system and our parasympathetic system. So again, remember sympathetic, fight or flight, a lot of activity. Parasympathetic is going to decrease those activities. And that's as simple as I want you guys to know it for right now. When we get into the area of cellulars, we kind of break down. I told you we have two types of neural tissue. We have our neurons and neuralgia. Neuralgia is basically everything else. So our basic unit, as we talked about with muscle so far and we talked about with skeletal, our basic unit is going to be our neuron. Our neuralgia is going to work out everything else around that aspect and be basically providing support, nutrients, framework, everything else that's going to be involved. And that's, again, as simple as I want to know. So the neurons, there are several different types of neurons that are out there and different neural bodies that come in. But they all have a basic shape to it. So the general area or structure of a neuron is something like this, where we have a cell body, or the main portion of it. We have an axon that goes out, and our axon is what takes out and is like our effector. Our axon puts the action potential out. That's where it's going to send our message, goes out our axon. And then usually we have dendrites, and dendrites are like our effectors, or basically this is going to bring a sensation into the nerve and tell the nerve what we want it to do. So they come in a variety of different shapes. They're based on the position that they are. They appear different ways, and they have different aspects of their appearance, depending on where they're found into the body. So a couple of different types that we see. This is what's called a multipolar neuron. And basically, a simple explanation for it is we have multiple dendrites coming in, and it goes and has a single axon, but it can control multiple areas. So multipolar is it has multiple different dendrites affecting on it, and it has multiple areas it can affect onto. Unipolar, basically, it has the dendrite coming in. It has one dendrite that comes in, has one axon that goes out, and it actually comes right off of the area, so it sits off to the one side. The multipolar neurons are what we're going to see most commonly out there because it gets a lot of feedback to it and it acts on multiple muscles. So I'm going to relate to skeletal muscles. If I'm dealing with a multipolar neuron to the back, I might have one or two because to move my back muscle, I don't have to do a lot, right? Big muscle. But to my fingers, I might have multiple on them because if I want to do fine movement, I got to have a lot of different sensations. I got to be recruiting a lot of different muscles to be able to pick up and to write. What these muscles, what these neurons do is these actually work in the system to work between organs and symptoms like that, where basically they're getting quick responses and quick actions, and they're just working on either areas inside the brain or on other type of spots where it's simple reaction. They're not working on multiple recruitments. But simply on this is basically one dendrite, one axon is going to be as simple as you need to know. A bipolar neuron is basically the axon is, the cell body is right in the middle. Again, one dendrite coming in, one axon going out, and it sits right in the middle. That's as simple as you need to know for that. And the different type of neurons out there, they can be for sensation, they can be motor, or they can be what's called an interneuron, so they work between neuron bodies. Unipolar bodies, neurons will also work between neuron bodies too, transmitting information as well. Our sensory nerves, obviously you know what we're going to do there. That's basically bringing in all sensation, proprioception, balance. It's going to relay in that information up to the brain. How it's going to get receptors, it's going to get receptors from all over the body. We're going to have our visceral receptors. Those are coming from the organs. We're going to have our baroreceptors. Those are coming from arteries and such, dealing with pressure to see how we regulate our systems. So all those areas are going to be coming in, and we're going to bring those up to the sensation for our body to regulate itself. Our motor neurons are basically going to be a majority of our body coming out, and those are going to be a lot of aspects which are going to come out to the body and give the action of what the CNS wants it to do. There's two different pathways that we're going to be doing with this, and that's going to be our somatic, and that's going to be our somatic, and what's the other one? Autonomic. Perfect. Those are going to be our two type of sensations that we're coming out and reaching the body. I'm not going to go over interneurons. So that's basically it. So as far as the cell bodies, then cell body, dendrites are bringing sensation to them, axons going out. Multipolar has multiple dendrites and an axon reaching area. Unipolar, the body is actually off to the side with one dendrite axon that's continuing. Bipolar, the cell body's in the middle with one dendrite coming in, one axon going out. Simple as you need to know. As far as neuralgia, neuralgia is everything else that we talked about, right? So that's everything that's going to be supporting it. And there's different neuralgia in the central nervous system than the peripheral nervous system. Unipolar.
That only had one dendrite.
It has a dendrite, axon is a continuous, and the body sits off to the side of it.
So is there any consideration for the axon, or is
The axon and dendrite are basically one type of thing. The sensation pathway comes one direction, but the body is actually off to the side of it.
Yeah. Okay.
The different type of neuralgia that's in the central nervous system, there's what's called astrocytes, oligodendrocytes, microglia, and appendable cells. I will tell you this one is going to be fairly important, and we'll talk about it as we go into it. Astrocytes, basically, these are what's going to maintain most of the body in the nervous system of working on each other. They're going to secrete different chemicals that keep the blood-brain barrier, which the appendable cells work with. And they're basically what kind of keeps the structure and the framework going. I'm going to have a good picture here and explain this later. The oligodendrocytes, these basically what do is they wrap around those axons and the dendrites. Basically, they're made up of what's called myelin. So in the central nervous system, these wrap up here. And you guys may have heard of myelinated nerves and unmyelinated nerves. Well, basically what their function is anytime you have a nerve, we get an action potential that comes down and runs down that nerve. When we have myelin and these oligodendrocytes, and I'll show you a picture later, will actually encase or wrap around the nerve and cause protection. We can now get this nerve pulse, instead of an unmyelinated area, this nerve pulse has to do this and go down the system. When I have this nerve pulse can jump basically each of these myelin sheaths, so it gets that nerve impulse to get places faster. So oligodendrocytes are very important because they form the myelin in the central nervous system to allow that action potential to move much faster. It's got a counterpoint in the peripheral nervous system that we're going to talk about as well too. But basically that myelinated area forms these barriers or wraparound, and these little gaps in between are what's called nodes or nodes of Ranvier. And those are basically these interjunctional nodes, which allows that action potential to jump and move much faster. Sometimes, depending on the nerve itself, 60% faster than some areas of getting that nerve potential coming in. And I'll explain some other areas of how that works.
Is that myelin sheet same length all over, or is it vary? Or?
It's the same length throughout the myelin modules. The nodes of Ranvier are equally displaced. So when I look here, and this is the picture I wanted to get into, so here, and this is a very highlighted area, is an oligodendrocyte. So this is the neuralgia right here, and it breaks off and it forms these myelin barriers that cover the axons and wrap around, and then this little portion down here is the nodes of Ranvier. And it allows that action potential to jump from here to down and forward and get very quick areas of moving across. These other areas in here are basically our myoglia cells, our astrocytes that form the framework of everything here, and our ependymal cells are basically forming what's called this blood-brain barrier to keep the central nervous system away from the normal body. So I've only talked about really one neuralgia, right? So maybe that'd be the important one to know. Maybe the other ones aren't as important. Fair enough? So in the peripheral nervous system, we just have two types. So we had 4 types of neuralgia in the central nervous system. In the peripheral nervous system, we just have 2. We have satellite cells, which again, this forms our framework and our structure and support, similar to what type of neuralgia in the central nervous system? Astrocytes. And then we have our Schwann cells, which basically our Schwann cells are a neuromyelema, which basically myelinate around the peripheral nervous system axon, similar to oligodendrocytes. So they do the exact same thing. So you can see that the Schwann cells will produce myelin, and it allows that nerve impulse to jump from here to here to here to here to here, and just really fast down that chain. And how quickly that nervous system needs to transmit that information determines on whether it's a myelinated sheath or whether it's not myelinated. Some nerves, we don't need to transmit that system very fast. They can be unmyelinated. Some things we have to transmit very fast, and so they're going to be myelinated. That's going to determine how much we need to be on there by how fast that area wants to go and how much we need to travel with that. As far as our organization system goes, we basically have spinal nerves, we have cranial nerves, and then the nerves itself have different functions. They can be a complete sensory nerve, they can be a straight motor nerve, or they can actually do both. Our cranial nerves are basically our nerves that stay just inside the brain itself, but they work on different functions, and they're coming strategically off the brain themselves. How many cranial nerves do you think we have? Almost. 12 cranial nerves. Yep. So you guys, I'm going to go over that at the end because that's something I want you guys to know too. So we got 12 cranial nerves. Those actually come off the brain, and I'll show you a position where they come. Then we have our spinal nerves. So those are ones obviously coming from the spine, and those are labeled off basically where they come out of the vertebra. So that's why our spinal nerves are related to C1, C2, C3, C4, L1, L2, L3, L4, and they basically hit different regions of the body, which are called dermatomes. And I'm going to go over dermatomes with you later too and why those are important. So as far as our central nervous system is going, we basically have what's called white matter, and we have gray matter. You guys have heard those terminologies before, losing gray matter? So white matter, basically the reason it's called white is because we have all these oligodendrocytes that wrap around these axons, and these axons in views are basically a white type of appearance. because that's what it is. It's basically this axon, these bundles, and so it appears to be a white matter. When we deal with the nerve bodies, and we're dealing with the cellular bodies on there, those basically have that ganglion and all those areas in there. That's the gray matter. That's the thinking process. So we always talk about. What's that? Is there someone in the office here? Who's it for? Okay. Yep. So we have our gray matter and our white matter. Our white matter are basically built up of our nerves that are in there. Our gray matter are actually going to be our nerve bodies, sensation from that, and that's as simple as I want to go from there. When we deal with nerve function, basically this is the same type of thing of having an action potential and sending that system out. So when we want to do something, we want to get something to move, we want our heart rate to go up, we want to have any type of action in the body, we have to send a nerve action potential. And how that goes is we basically have to send it down the nerve and send it down the axon. Well, to get that area to move, this is again where we're bringing in our sodium-potassium pumps and we're going into an action of getting that action potential to go, or a electrical response is realistically what it is. And how we do this is balanced with anions and cations. So our resting potential of where our body basically sits is we sit on our cellular level in the nerves at basically at -70 millivolts, which basically means that we are keeping most of our positive anions outside the body and our negative ones inside this action potential. And when we want something to do, we say we need this impulse, we want something to go, we start to open up those channels, so we bring sodium to flood in the system. Sodium is positive. Once we pop over this threshold of this -70, we start building up with positive anions. We get a recruitment, or we get an action potential to start, and this basically starts down the system of opening up sodium channels, allowing them in, and it moves that area down. Depending on what we want to do, where we want to act on is where we want to go with that area. So we'll basically open up along the nerve channels of where we want to go. So if I want to move my finger, I'm going to open up a nerve potential from the area of my brain that tells me I want to move my finger, down the spinal column, down to, what do you think nerve comes down this way? Okay, but how about a, which nerve root do you think it comes off of? So we'll go kind of on dermatomes, but we'll basically talk about the levels that come down here, basically where C4, C5, so those areas come in. So you can be able to tell if I can move my hand and I've got feeling here, but I don't have feeling here, I can start to tell where the level of the nerve that came from to where my level of injury could be with spinal processes. So again, that's where I want you to know is where the action comes into is which area, especially if we're dealing with spinal fractures or spinal injuries, what effect of the body are we dealing with? So when I get into dermatomes, I get kind of off track here. I apologize for that. But that's where we want to go. So basically, if we want to go into that direction down there, that's where I'm going to set an action potential. And I'm going to open up sodium-potassium, sodium channels all the way down to keep that action potential going, all the way down to my muscle. And once it hits that muscle and it gets all the way to the end of that synaptic clefts, it's going to release that acetylcholine. Yep. Releases sodium, correct, you're right. Sodium all the way down until it gets down to the synaptic cleft. The synaptic cleft, then it's going to release acetylcholine. It's going to cross the cleft, attach to the sodium-potassium channels to then allow sodium to drop into the muscle, which is going to start the calcium to release and start a whole process. So that's the effect of what we're doing. So we're opening up those channels, and that's kind of the movement that we're doing. There's different ways that we can do this. There's passive channels and active channels that are going to be going as far as opening those up. I'm not going to go that as far as in the test. Again, if you get that basic process of how that works that I'm going to go over to, that's all I really want to touch in. So we get an action potential. Here's our local current. And we're more negative inside than we are outside. That's kind of where we go. So now we want to depolarize. We want to start that action potential. What happens is we get a function that we want to do, an action that we want to do, somewhere act on the body, and now we open up that channel and we flood that area with sodium ions or positive ions, and that starts a chain reaction that moves down the system. So it opened up here, and we got it flooded, then it closes. Then it opens up here, and it'll continue opening up down all the way down that nerve until we get to where we want it to go and get to our final potential. Once that area is done, and we've crossed the area, and we've opened it up and we've moved down, we've got all this sodium inside, right? We've got to get it back to a resting potential, so eventually we'll pump all that sodium back outside, and that'll reset our body to get another action potential again. So we open the sodium channel, flood it, starts moving down the system. Now we have to pump that sodium back out, so we reset ourselves, and that's the recovery phase of how we move action potentials up and down the body. When they talk about a graded potential, this is kind of the same thing as when we're talking about recruitment. Depending on to the response we want to do or the action we want to do, we have a graded potential, or basically the stimulus to open up on that sodium-potassium channels, basically our sodium pumps, and how quickly we want to move it. So we're going to open that up. We're going to cause a depolarization. We're going to get those channels in, and we're going to keep moving that action potential down, and it's going to be keeping moving down that entire lapse of the axon until we get to the function it wants to do and it completes what it does, whatever reaction that we want it to do, whether it's a skeletal muscle fiber or wherever we're going to. So that's going to promote that action potential all the way down to the end. And here's an example again of this. So similar to the muscle one, right, that we dealt with. So we're at a negative threshold. We start the action potential. We pump it in, and then our body goes through this refractory period again where it pumps out the area the body's ready to do for another action potential. So it's open to sodium, it's pumping it back out. And that basically keeps resetting our body to come into. If we want to do a continuous reaction, we may be shooting multiple areas. If we get having to reset that over a quick period of time. Sorry, my mouse keeps leaving on me. To basically keep propagating that area. So from our cell body, we want to keep it moving, and we keep this local current, and we keep moving back down. So as we keep this area of sodium keep coming in, and we keep moving that down, this repolarizes and starts pumping it out, and it's ready for another action potential to keep coming and keep sending it down if we want to keep those motions going through. So that's the body continuously recycling itself, going into an area to promote that current or that action potential down to the body. Now the purpose of the myelin, especially coming over here again, is those jumping areas I talked about. So if I propagate that nerve down an area, you can see how long it takes to keep opening up sodium channels all the way down, correct? What the purpose of these myelin sheaths are it jumps these potential. So now instead of having to open up all the sodium channels in this area, it just opens up here and here and here and here. So you can see how much faster that current is going to be able to travel when you have a myelinated sheath versus not having a myelinated sheath.
Why wouldn't your body use that for all of your fibers? And it seems like it'd be less energy having to use less stuff pumping it out.
So in most of our skeletal, they come out that way. But I'll give you an example. So sometimes we need them to be traveling a different way. Now this is slightly different, but I'm going to talk about the cardiac aspect. Okay, just to give an example of why sometimes things are faster or slower than others. So when we deal with the heart, and we've got our chambers, we have our sinoatrial node, we have our AV node, and then we break down to our bundle of His and our Purkinje fibers coming up. So this beat to here is a set beat. So here I can have myelinated factors basically because I want to get that contracted to that spot. And now I get my atria to beat. Now I'm going to want my ventricles to beat, right? So I'll get this component here. But if I have this part here that transmits, because there's nerve action potentials in here too. If I transmit too quickly into here, I can actually get my ventricle to contract a different way. So the actual speed from here is so much faster because I want this to actually contract this way. So some nerves I want to move actually that area faster to into slower areas. So there's some parts of the body where we're dealing with smooth muscle. So when we're dealing with skeletal muscle, those are pretty much all myelinated factors. We're dealing with smooth muscles, and we want to deal with an action potential going down, and we want peristalsis. We want it set in a certain way, and how those are reacted, those are responded by non-myelinated sheaths. So there's just different things, and I don't have a great answer for you, except for in this is the body works different ways. And some spots we don't want a quick response to it, some parts we do. And it doesn't actually, because this is there, this isn't actually energy per se, it's just about the speed of the motion of how quickly that response is going. And there's some parts of the body that we don't need that fast response to, some that we do. Some we want to maintain, especially when we're dealing more with the visceral and the organs. We just are going to maintain a constant current. We don't have to be quick, so they're not myelinated. But it's not taking extra energy to respond to that, if that makes sense.
Okay.
Fair enough? Clear as mud? Nice gray area. So once that action potential reaches down to the end of the nerve, it basically will reach that synapse that we talked about. And that's where the nerve basically is attaching with the muscle, attaching with the viscera, attaching with whatever organ it wants to put an effect on. That's where we have that synaptic cleft that I talked about. And then we have the synaptic terminal. Again, I like pictures here. So here's basically where the nerve is coming in, it's interacting with whichever organ system it wants to work on. We have the synapse on here, and all these little vesicles in this area at the very end of the synapse. So when that action potential comes down the nerve, it releases here, it causes those vesicles to then be released. And here's all those vesicles in electron microscope picture. It's going to release those vesicles, they'll cross synaptic clefts, they'll attach to the receptors to open the channel, allow that action potential to cross, because as they attach there, they're going to release sodium down into the system. This one is actually showing calcium also goes back up into the synapses. You don't need to worry about that. We're talking more calcium mostly in the sarcoplasmic reticulum. That allows the communication to go in, work there, and then once that system is stopped, or that action potential is stopped, it stops releasing the acetylcholine into the system. The vesicles come back in, it restores itself, rebuilds itself for the next round, and then acetylcholinesterase will bind to whatever acetylcholine is left in here, pull them off those receptors to stop and close those channels. And that's what stops the action potential.
Where's acetylcholinesterase go after it's done?
Still maintains in the system. Once it binds, it breaks down. So your acetylcholinesterase is kind of in there, and it's taken back up in the system. Then your body will release it as it needs to be. So basically, when you get those initial action potential, you got acetylcholinesterase that's in the synaptic cleft, but you're releasing so much acetylcholine that some of it's going to get picked up, but most of it's going to be binding. Now that you stopped releasing it, the action potential stopped, the acetylcholinesterase that's in there is going to start binding not only to everything that's out there, but excess coming in is going to start binding to those that are coming to the receptors. But you're flooding it, that action potential actually floods it with so much acetylcholine. You always have acetylcholinesterase in that area, but you're flooding it with the system. So when we talk about the polarizing agents for paralysis, what we're doing is we're flooding the system as well with acetylcholinesterase, so it doesn't matter how much acetylcholine comes in, we're blocking those potentials.
How long can acetylcholine be used until it's either broken down or recycled or anything? I guess you say, is there a lifespan of acetylcholine?
I have no idea. I know it's brought in, taken back out. So your body, your synaptic clefts keep rebuilding it.
And it's reused though as well.
The body's reused except for those that are broken up and taken down. But I don't have a great answer for that. Great question, but I have no idea. Other different type of neurotransmitters, we're going to talk about mostly acetylcholine, but there's norepinephrine, there's dopamine, there's GABA, there's serotonin, there's lots of different types of neurotransmitters. We're going to talk about specifically acetylcholine, but when we're dealing with the brain, GABA, dopamine, and serotonin are big components in the central nervous system that can also be used. So why are these important to you? Well, because we use a lot of these different medications, and we have different things that react with those. So I want you to be aware of what those are, of the different transmitters and how they work. Gases can act as neurotransmitters. Nitric oxide and carbon monoxide can also be neurotransmitters. These are the same things, and these are the type of things that we use out in the field in some areas. Some people actually have nitrous oxide that they carry on their rigs that can be used. We see them in dentist office all the time, right? Because it can also be used as a depressant. So these are the other type of things that are out there. And carbon monoxide, we think about if it's affinity binding, but it's actually a neurotransmitter as well that can be used.
Are there medical uses of carbon monoxide?
None that I'm aware of. There could be, but none that I'm aware of. That's one way. Be an easy way there. And so those nerves are going to basically be communicating with itself, acting on itself. How acetylcholine and norepinephrine are going to be our two main areas. I just want you guys to be responsible for acetylcholine. That's all I'm going to hold you responsible. I'm not going to talk about dopamine, gabapentin, or serotonin and how those work at this point in time. The basic communication, again, is going to be either efferent or afferent. Efferent, again, is what? It's the action. Efferent is going to the signal. It's going away from the central nervous system. It's going acting on the body. And there's afferent, which is coming back to tell the brain. So efferent is usually motor. Afferent is normally sensory. It's a good way to kind of remember that. And how those can go is that it can either diverge down, where I have one action and I want to work it on several areas, like when I want to move my fingers. I may have one action to say I want to pick up this water bottle, but I need multiple different muscles that come in, so it's going to diverge out to multiple different muscles to give that same signal. Or I can have convergence, where basically I want to do one thing, but I need several different areas of the brain that's going to function that area. This is dealing more with proprioception or heart rate or other stimulations. I got multiple things. I got input from my thalamus, from my hypothalamus, from my pituitary gland, from my adrenal gland, all acting on one system that's going to work on whether I produce angiotensin and my kidneys or something. So I can have convergence where I have multiple things acting on one thing.
Would smell be a good example of that? Because you have to inhale and do your perception of taste or whatever.
Yeah, when you're dealing with more the afferent side. Yep. So that's all I want to talk about as far as the nerves. Next thing we're going to go into our central nervous system is its component and what it's built up into. We talked about the main nerve tissues and the neuralgia out there, but basically, as we talked with everything, there's something that surrounds and protects that. What we have for the central nervous system as far as protection is what's called the meninges. Meninges are very important. Basically, we have 3 layers, and these 3 layers are also very important to know. So you have the dura mater, which is going to be your thickest layer, and you're going to be your outermost layer. You're going to have your arachnoid space or area that's going to be in between, and you're going to have your pia mater, which is your most internal coverage. And basically that dura mater is a thick fibrous layer. This is what attaches to your skull, and this is what's on the most outside layer. It's going to be your thickest and most protective layering on there. You have what's called your epidural space. This is pretty much kind of where your arachnoid layer is. And that's going to be the spot that's inside the area where that fluid's going to be. And then you have what's called the subdural space, which is your dura mater and your acnoid layer. So it's going to be a small spot in between those 2 layers. Not too important to know from this aspect, but there is an opening space between those. Your arachnoid layers is basically your middle layers where most of your fluid is, and it's basically like a webbing area. I'll show you a picture of that here soon. And that's your space, and that's where your cerebral spinal fluid flows mostly into. Your cerebral spinal fluid does a lot of different things. Not only is it fluid to bathe the brain and get some shock absorption, but there's a lot of nutrients that are done, and it actually does some transmitting as well. And then your pia mater is the innermost layer, and this attaches directly to the brain itself and to the nerves themselves. And that does most of the communication. That deals with the ependymal cells and does communication there. So here's kind of a picture of the central nervous system and the spinal cord. When we're coming down, so this is still all central nervous system until it leaves. So when we're dealing with this main component here of the spinal cord, this is basically what it looks like. So you've got your spinal cord is right here, and this is all central nervous system axons that fill this area and cell bodies. And then when it leaves out this area here, this is here where it then becomes peripheral nervous system. And that's that combining component. And each of these nerve roots are based on the layer or the level that it's coming out with from the vertebral column. I'm not going to go into the positions up here, but basically we have what's called the anterior horn and the posterior horn. This gray matter, again, is all cell bodies. And this white matter here is all axons and other potentials and other aspects of that going in. So out of this central nervous system, there's 31 different roots that come off that. We have dorsal and ventral roots, depending on which side they come through. What's my back called of the body? Dorsal or ventral? Dorsal, ventral. So when they come in through that, the dorsal ones are going to be usually our sensory, and our ventral ones are going to be motor ones, as far as nerves coming out. Last aspect of the spinal cord coming in is the spinal cord will eventually stop. Does anyone know what level it stops at? Let's see if I set it up there. A little bit higher.
L1.
L1. Yeah, so when we do spinal taps, you kind of bend people up in those areas go. So the spinal cord will stop, and then it turns on what's called the cauda equina. And so then those are actually nerve roots that just come down at that point in time, out, and then go back down to the body and continue to go out through the other layers. But the central nervous system, the spinal cord actually stops. So as we're looking at this again, we talk about the gray matter. These are all cell bodies. So this thicker area right down in here are the motor neurons, and these up here are going to be the sensory neurons, which are a little bit smaller for some areas coming in.
So you said the dorsal roots are the sensory ones, correct?
Dorsal or sensory, ventral or motor. Okay, so that's all I had for you on this one. I'm going to talk quickly about the brain. Let's take another 10-minute break. I've got a little bit on the brain, going to talk specific there, and then we're done for this.
Study, right?
I don't think you should even have that much for me. So, but I'm not talking about the book. So, yeah. So I'll condense you. I'll take care of you on that aspect. So, dealing with the brain again. These are different sections here that you do not need to know for testing purpose or anything like that. The main thing I want you to know is the cerebrum, the midbrain, and the cerebellum. Is knowing where those positions are and having a function when we're dealing with a brain of what we're dealing with. Other things are very important and have a different aspect to it, but those are the basic contents that I want you to know. So when we're talking about the cerebrum, we're talking about our main brain. That's when we talk about the brain, that's what we talk about. This is our main function centers. Sits up in both hemispheres. We have our right and left that talk on there. We talk about people being right-sided or left-sided functioning in brains. This is where we're kind of talking about that aspect. And in this whole area, put my pen on, of the cerebrum, basically is the majority of our brain, right? This has everything into us. This is our thought processes. This is our speech centers. This is our motion. There's actually a great picture, which I'm not going to show you at this point, but I'll talk about later, what's called a homunculus. And what a homunculus is it's an animated drawing of the brain, which shows the different areas that move from your hand, your eyes, your mouth, your feet, and everything like that. But this is basically the whole thought process. This is us as far as the brain. When we talk about the cerebellum, what does the cerebellum do? What's fine movement and coordination? That's the main function of it. That's our main function up here, but our cerebellum's main function is coordination, fine movement, proprioception, balance. That's where all that stuff comes into. And then we're dealing with this as our brainstem. Is this whole aspect right here. The medulla oblongata and this brainstem, That's our mammalian responses.
What algae is showing.
That's right. Okay. Nice. So this is our main area that which tells our function, right? This tells us how to breathe. This keeps our heart rate going. So where does this area go? Comes down and comes through our what hole? Foramen magnum, right? Okay. So why is that important? Well, this is important when we get into later and talk about ICP, intracranial pressure. So when we have that into the area and we start getting pressure inside our brain and it pushes our brain down, because fluid pushes our brain down, we push this section through the foramen magnum, through that small hole. As it gets compressed, it messes with our system. So what does that do? It throws off our breathing. So our breathing becomes erratic. It either becomes really fast or becomes slow and fast in different range, or we get a decrease in our heart rate because it affects our vagus nerve and it drops that. So any effect or pressure on that affects our ability and it changes everything off. That's why ICP, we talk about intracranial pressure, is so important in knowing this area. And the medulla oblongata and the brain, part of the brainstem is a huge aspect of those controls. But our cerebellum is our fine movement, and this area here is all of our main speech, motor sensation, personality traits, all those different things. So that's that main component.
That's Cushing's triad, right?
Cushing's triad is when we talk about intracranial pressure. Yep. So when we're dealing with the brain, those are the main areas here. I'm not going to talk about the gyra and everything here too, coming in around the spot. But basically, this is the main function here. So here's where I'm going to go to, and I'm going to talk about a concept for you. And the reason I'm bringing it into now is because it can affect you guys out in your normal practice. Because this is something I just learned out at a stroke conference and I've been doing it. Well, my background again is in sports medicine, and that is not in internal medicine and anything like that. But as a paramedic, I was never taught of something called posterior stroke. So I'm kind of getting off my area, but I think this is important to know. Anyone ever heard of posterior strokes? Josh? Okay. Do you know what it is? Okay. So I didn't either, but I'm going to tell you a quick story of why this is important in here. So anterior stroke is basically when we get something blocking through our carotid arteries, comes up and affects our cerebrum. So what do we test for a stroke? Face. So our face is basically our ability to smile. That's off one of our cranial nerves. It comes from our cerebrum. Arm drift. Motor sensation, again, comes from our cerebrum. Speech comes from Broca's center in the brain, which is a speech, part of our cerebrum. So we do those tests, right? Well, the carotid arteries come up, it fills the cerebrum, supports that area, goes into an area called the circle of Willis. Circle of Willis then comes down to our posterior aspect. So we have another set of arteries that come up to the brain too. It's called our vertebral arteries. Our vertebral arteries come up the backside of the spinal cord, and they come up and they start feeling our midbrain, pons, medulla, and our cerebellum area. And that circle of Willis sits up here and it deals with the ventricles and that aspect, so it comes in here. So if I have an anterior stroke, or I'm dealing with that main anterior on the anterior side of the circle of Willis, this is where I'm going to have my disorders and I'm going to be able to tell. Now, if I have a clot coming up my posterior vertebral arteries, where is that going to affect? Fine motor movement. So how do I test if someone's having a posterior stroke? There's a great test for it. That's one of them. Potentially in there. But you know who's great at doing posterior stroke testing? Police officers. That's your drunk test. So because you're doing fine motor motion. So exactly what you're talking about. I hold my finger up here, and I tell you, touch my finger, and then touch your nose. Touch my finger, touch your nose. He can do that, he's having sense. If he can't do it, it's one. Fine motor motion, doing this. Doing this. Doing eye motions as well, because that's also involved. So when I'm coming around and I'm checking the vision. So a reason I want you to be able to aware of this is because if you have someone who's having stroke-type symptoms, because of flow up into the area, and I actually just had a patient, I was telling Gary about this, just had a patient the other day who had this exact same type thing. Definitely having stroke-type symptoms, but he talked normal, face was normal, motion was normal, everything was normal, but as soon as I did the test of the finger, he missed my finger and he missed his face. When I had him do this, he started doing this.
Is this something to incorporate into our routine fast exam from now on?
We're going to talk about it as we come in too, but I basically put it in the back of your mind because this patient had this. I called it into an activate. They said, no, don't activate, but come in. By the time we dropped him off at the hospital, he had converted and had gone through, and now he all of a sudden his arm went away, and it was a full progression.
It seems reasonable and easy enough
So
to do that.
it's something you can throw, but if they've passed the fast exam, you don't have to do a posterior. But if they've had the symptoms of a stroke, and it's not there, it's something I want you guys to be considering out there because I hadn't heard about it before, so I'm just passing on some information since it fits right into the area where we're going into. So we're talking about blood flow to the brain and those things. But again, it's something out there, and it's about 35% of strokes are missed that start off as posterior and convert, something I picked up in a seminar that I wouldn't even know. So
you said they passed the fast exam, then switch to that, or?
well, if they pass the fast, they're having stroke and they have a positive fast, that's all I stop at, right?
Yeah.
So
But you like want an altered patient.
if they're still altered from another aspect and I've ruled out everything else, that's an option I can do. And as long as it's not alcohol or drugs related or anything like that. So other alternatives to you. So as we're dealing with the area, again, our cerebellum, like I talked about, this is basically going to be dealing with our fine motor motions, proprioception, everything from there. We have the different areas of the ventricles. I'm not really going to go and hold you guys responsible to the diencephalon and the four ventricles in those aspects. It's a lot of important aspects, and neurology has a big important thing to it, but I'm not going to hold you guys responsible for any of those stuff and the ducts and that. So cerebral spinal fluid, I am going to hold you to. That is what, again, bathes and causes cushioning around the brain, but there's also communication. There's nutrients, there's waste products, all different aspects in this. And this basically covers the entire brain and down into your spinal cord as well. So important aspect from there. Also, we're going to check for the head trauma or any breakage of the area. If there's a break in a skull, usually you see leaking of cerebral spinal fluid, either out the ears or out the nose. So that's another way to test and stuff if we have potentially a fracture that's associated with it. We're looking for the halo testing you guys are all familiar with.
Does that terminate the cerebral spinal fluid in the spinal sac? Does that terminate like that L1 where the...
In the cauda equina. It actually goes down, so where the nerves terminate, that little sac goes down a little bit further. So where do we do spinal taps at? The lumbar spine down below. So we're below where the spinal cord terminates, but we're still down into where that sac comes, and that's where we go. So that's why we'll bend down. So the spinal cord usually terminates about L1, but we'll do lumbar taps about below L2, L3 area there so that we're not hitting the spinal nerve roots. Great question.
Is cerebrospinal fluid like a very viscous thing as well?
Yes.
So it's like...
It's got some viscosity to it as well, so when you touch it, it comes through.
So if you go on like a head injury, is there a way to tell between cerebral spinal fluid and just mucus?
So you're going to be able to tell it when it's in blood or you see drainage. That's that halo sign. So if you put up a 4x4 or something to it, and you see kind of a clear fluid by a red tinge around it, that's positive for the cerebral spinal fluid. That's our best test for it. But it's going to be a lot different than necessarily a mucus will be. There'll be blood associated with it. That'll be the difference associated there. Again, we talked about the cerebral spinal fluid flowing around through in here and the meninge layers and knowing those levels of the meninge.
So where does the CSF transfer waste and nutrients at?
It goes through the lymphatic systems.
Okay.
As far as the hemispheres, I kind of went over all the bilateral hemispheres of the cerebrum. Each of the lobes are going to be identified, though, like we did with the skull itself. So as far as we're dealing with the cerebrum, we have different areas. So we're going to have the frontal lobe. We're going to have the parietal lobe. We're going to have the temporal lobe. We're going to have the occipital lobe region of the brain when we're associated with injuries in that. And each area, and when I show you a picture of a homunculus later, it's going to show you each area of the cerebrum and what areas of part of the body it affects and where those areas are. But this kind of talks about it and just gives you an idea of the flow of where they're coming into. Broca's area is usually right into here. We have our auditory canal, which comes right into that spot. So all those type of areas to around the brain are going to be seen when I show you homunculus on another picture and show you the specific. But again, this is our cognitive functions. This is everything we do from motor, sensation, thought process, creativity, speech, here, all that stuff is going to be related into this area. And that's basically what I stated right into there. These are all areas that I talked about: Wernicke's area, Broca's area, speech center. So these are all areas that we're talking about in those prefrontal lobes that I've kind of talked to you about as far as going over each of the motions. This is a little bit starting to get in. This isn't quite the homunculus area, but this will talk to you about the brain itself. So we talk about getting the information from inside the brain down to the other side. Well, where it starts with the cerebrum, there's actually, along the central sulcus, that area actually crosses where the nerve response goes, and it actually goes to the opposite side. So I've got an area over here on the right side of my brain, and it tells me, hey, I want to move my hand and start writing. If I'm dealing on the right side of the brain, as soon as it passes the corpus callosum at the intervertebral area and come down, it actually affects the left side. So injury to the right side of my brain actually can affect the left side of my body. Injury to the left side of the brain actually affects the right side of my body because those transmits down that way through the corpus callosum. Why that happens, I have no idea. Don't know the purpose or reasoning for that. I haven't looked into it. It wasn't that important to me from that aspect. But the idea is that's also going to be able to tell you what side of the injuries you're going to be looking for. But that corpus callosum is where that area crosses and transmits the area from the right side to the left. Different ways we can check from the patterns and an electroencephalogram. I'm not going to go into those, but there's different wave patterns that are out there. We have alpha waves, beta waves, theta waves, and delta waves. These are basically important activities of seeing how the brain is active, how to check that for activity levels and see if there's trauma levels. Honestly, over this stuff, I don't know much about these type of things. It's not part of my area of study, but neurologists can do this. They can tell how well the brain is working. These are great for checking out for when people are in comas, other activities for brain activity. I'm not going to hold you responsible for any of those information, but there's a lot of great things that they do with this. I just know nothing about it, so I'm not going to pass any information on to you from there because I haven't done sleep disorder or neurology as a background. This is the last part I'm going to leave you with, and I am going to hold you responsible for, is the cranial nerves. So there's actually 12 cranial nerves. I'm going to pop to this page, which this will go over each of them and what they are. But here's an example of the brain. And basically what we're doing is we're looking from inferior to superior. So this is the bottom of the brain. So this tells you specifically where they're coming off of. And they come off in order in this angle. This is basically the spinal cord here, the brain stem coming up to the hypothalamus, coming up to the brain, and then all the way up in here. So the 12 cranial nerves in order, what I do want you to know is I want you, if I said what's cranial nerve number 7, what's cranial nerve number 5, what's cranial nerve number 9, what's cranial nerve number 11, 12, I want you to be able to tell me what it is, what's the name of it. So this is a good example here: olfactory, optic, oculomotor, trochlear, trigeminal, abducens, facial. And you guys should have this on your book. I don't know what page it's in. But if you look up cranial nerves, it'll tell you exactly this page. But the other aspect that I want you to know is this. What does it do, and how are you going to test it? So olfactory, very easy. Coming our nose, that's going to be smell. So doing anything with smell sensations, you're going to be able to test it. Our optic nerve, that's going to be your vision. Can they see? When we deal with our ocular motor and our trochlear, those are going to be our motions of can our eye move to the side. That's when we talk about the H test of going over and watching how well that eye moves and is it able to move in all areas of vision. Trigeminal, this is actually our muscle of mastication. So this is our chewing muscle. Abducens is basically another muscle that's also going to be working around the eye as far as the eye motor motion, not vision, but as far as motor. Our facial nerve, this is going to be basically our facial expressions. This is going to be our smile, our grimace, anywhere there. Our vestibular cochlear nerve, this is going to be actually be into the ear canal, and that's going to be our balance and hearing sensation. Glossopharyngeal is going to be actually back of the tongue, which is going to be our taste, also our gag reflex. Vagus nerve, number 10, that's going to be our parasympathetic responses, which basically we talk about rates of the heart rate, breathing rate, everything from there. Accessory muscle, that's going to be coming down the side, and that's going to be dealing with everything with our shoulder shrugging, trapezius muscles, other areas there. And then the hypoglossal is going to be with our swallowing. It's going to be kind of associated with the tongue area and right down into the throat and be our swallowing and speech. So based on each of those, you should be able to find a way to test those. But I want you to know each of those. So if we gave you what is cranial nerve number 3, you can tell us the name and what it does.
So those last 2 slides, they're in the book, because they're not in my slides. I don't think anybody else.
You should have, again, this is a drawing, but you guys should have actually a picture of a brain that should have it in the book.
Pictures on 295.
Yep. So 295, it's actually a drawing of the brain. You can see it all right there.
And then 297
Is the chart. Thanks. And that's what I got for you.
What's the glossopharyngeal nerve component?
Glossopharyngeal is base of the tongue, gag reflex, taste.
I thought that gag reflex was vagus.
No, vagus. Vagus has got. Well, they both have gag reflex. Vagus is more your innervation to your heart, other sensation too. The glossopharyngeal is your taste and gag. I guess they both depend on the area, but oropharynx have a little bit of gag reflex to them.
So on our chart, that was in the book, it shows some have sensory and motor. So if I'm know what those are.
I'm not holding you to sensory or motor.
Okay.
So more of what it does, and what the name is and how you test it. But you don't need to know for me whether it's a sensory or a motor or both.
You need to know the number.
So if I said cranial nerve number 3, you should be able to tell me what it is. That's kind of what I'm looking for. Sound good? Questions?